Hello. Good evening, everyone, and welcome to the EUROGEN webinar series. So just before we kick off, I'd like to take a couple of minutes to introduce what the European Reference Network is and what we do. So EUROGEN is one of 24 European reference networks that were created and they're funded by the European Commission in 2017. And they cover different medical fields. And EUROGEN covers rare urogenital diseases and complex conditions. So we're really dealing with highly specialised surgery where the expertise is rare. And we're currently a network of 51 healthcare providers in 20 member states. And what we aim to do is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions. And some of our activities are, I hope you took note of the slides at the beginning of the meeting. So we have virtual consultations using a secure IT platform that's presided by the European Commission. So we have teams of experts who can help diagnose or suggest particular surgical approaches. We also have training and education activities, and we're developing a EUROGEN patient registry, which will be very useful going forward for research purposes. And we also work on clinical guidelines. So this evening's webinar, without further ado, is about fertility issues in testicular cancer. And we're really delighted and honoured to have the team from one of our members in the Czech Republic, and they're all from the Institute of Biotechnology at the Czech Academy of Sciences in Prague in the Czech Republic. So firstly, we have Associate Professor Katerina Komrskova, who is Head of Group Reproductive Biology. And she's at the Institute of Biotechnology of the Czech Academy of Sciences. And then we have Professor Tomas Buchler, who is head of the Department of Oncology, and he's at the Faculty of Medicine, Charles University, and Motol University Hospital in Prague at the Czech Republic. And then finally, we have Professor Roman Zachoval, and he's at the Department of Urology, the third Faculty of Medicine at Charles University, and Thomayer University Hospital, also in Prague. So we really thank you very much to our trio of experts, and we really look forward to hearing your presentations. Thank you so much for doing this. Goodbye.
So, ladies and gentlemen, colleagues, it's my pleasure to present you result of our study, which could be in the future implied into clinical practice. So for the purpose of this talk, I would like to touch the sperm development called spermatogenesis, and it starts with the puberty within the seminiferous tubule in epithelium of testis, as you can see on the sagittal section on the right. The completion of the whole spermatogenesis cycle takes between 68 and 74 days in human, and this is particularly relevant for our study, as you will learn on the next slide. On the cross-section of seminiferous tubule on the left panel, you can see concentrically developing male germ cells with the sperm in the lumen, with the white sperm in the lumen, and these sperm will be passed through the rete testis into epididymis, where they undergo the epididymal maturation. The male germ cells, the male germ stem cells, are actually called spermatogonia, and they are located around the basal lamina of the seminiferous epithelium. They are continuously mitotically divided into daughter spermatogonia, and these enter meiosis to produce spermatocytes and later spermatids. Spermatids then undergo complex differentiation into immature spermatozoa and obtain its typical shape and functional organelles, and then are passed into epididymis, as I mentioned already. So now, I would like to briefly introduce the objectives of our 3-year ongoing study. As a part of the oncofertility program, so far 47 men diagnosed with testicular germ cell tumor between age of 18 and 38 have been included into the study. These men have 3 cryopreserved samples, and the first sample A was collected before the orchiectomy, and therefore sperm development was challenged by the cancer. Next 2 samples were collected 3 months, sample B, or 6 months, sample C, after completion of chemotherapy. It is important to stress that for these 2 samples, B and C, spermatogonia stem cells were the only germ cells exposed to the therapeutic intervention, as you have already learned on previous slide, because spermatogenesis takes about 2.5 months. So our questions were 2. Do these samples differ in sperm quality? And does it matter which sample is used for assisted reproduction technology? Well, one could argue easily that it does not matter which sample, as if we look at the standard WHO spermiogram below in the table, you can see that testicular germ cell tumor sperm fall into the category of normozoospermic fertile men, even though these patients suffer with infertility issue, and you can see several parameters which are actually listed in this table. Therefore, there is an urgent need for detailed analysis and new diagnostic methods. So our approach was complex, but in a way simple as well. So first, we focus on assessment of tumor progression and sperm quality parameters such as acrosome integrity, I'll speak about it later, DNA integrity, motility, and apoptosis. Secondly, assessment of testicular and sperm mitochondrial activity was an important issue. Thirdly, multiparametric correlation of testicular germ cell sperm pathology assessment was done based on these parameters. And based on the above 3, proposing new method for testicular germ cell sperm diagnostics and proposing a set of diagnostic markers for sperm quality diagnostics of patients to be used in assisted reproduction. So at first, we use fluorescent intensity marker staining of Ki67 proliferation marker to detect severity of TGCT and correlated with the standard histology staining, as you can see in these 2 panels. In the panel A later on the right, the individual patients' Ki67 fluorescent intensity differed significantly, as you can notice based on different colors here, and patients were listed under individual unique numbers. However, as you may appreciate on the panel B below, when these data were compared between tumor and surrounding non-tumor testicular tissue, the percentage of Ki67 staining was similar and rather very high in range between 60 to 85% of positive cells. So using this approach at the beginning, we obtained overview of individual patients' tumor status and could later correlate it with the results of further methods. So at this stage, using multi-sperm quantitative and qualitative parameters listed on the right, we focus on comparison between our samples of interest, so A before orchiectomy and samples B and C 3 and 6 months after chemotherapy. Interestingly, and maybe surprisingly for you, the worst sperm parameters were obtained in the sample C, especially for the viability, acrosome integrity, and DNA damage. So probably here would be relevant just briefly mention that the acrosome is a vesicle on the top of the sperm head, and it is critical for sperm passing through the egg surroundings and fertilizing the oocyte. So one could expect that spermatogonia stem cells could have recovered within half of the year, but the opposite was actually true. It actually appears that complexity of the chemotherapeutic damage on spermatogenesis, evaluating these qualitative parameters, may be long-term. Interestingly, when we focused on viability and apoptosis, So for the apoptosis, the number remained high for live cells, and evaluating anti-sperm antibody, particularly for IgA, was the only parameter which may be dropping down in sample C to the level close before the orchiectomy. So we found that rather interesting, and we would like to take this data further. So the sperm swimming, so-called motility, is one of the critical parameters for sperm function. And you may wonder why we measured total and progressive motility, as you can see in these two graphs. And what is the difference? Well, for simplicity of this talk, total motility gives us feedback about the percentage of sperm with any movement. However, during physiological conception, it is essential that sperm become so-called hypermotile and obtain progressive motility, which is reflected by much higher force, different sperm tail beating, and also different trajectory. This motility allows sperm to penetrate the egg surroundings, similar to the acrosome, which I mentioned on the last slide, on previous slide, and fertilize it. So moreover, and I'd say importantly, this kind of motility is only obtained during sperm maturation in reproductive tract in women or in vitro, and this process is called capacitation. That's why you see the capacitation media mentioned there. So progressive motility reflects functionality of sperm. And as you have probably already noticed in the right graph, it is declining from samples A to C. And on average, in cryopreserved patient samples, it is actually below a critical level of 32% according to WHO guidelines. So in the next slide here, I present you the same data, more or less, just quantified and clustered according to types of sperm movement. So you can notice that majority of sperm display slow movement, and it is likely one of the major reasons due to low number of functional sperm that these men suffer with infertility. In this slide, as data suggested, severely compromised motility would be cause of unfunctional damage mitochondria, which are essential for ATP production. And so we were interested in ultrastructure of sperm. In this slide, you can see the scanning electron micrographs. Well, it disappeared now, so hopefully it will come back. Electron micrographs, you can compare normal, healthy sperm on the left and damaged slow or no motile sperm on the right, with damaged mitochondria, which is circled, and also damaged acrosome. So motility is, and in the graph C, it's disappearing for some reason, I apologize for that, but in the graph C below the pictures, the motility was correlated with the length of the tail where mitochondria are placed, and that piece is called mid-piece, and you can see in the graph that it is actually shortened in low or no motile sperm based on individual samples. So when we focused on transmission electron microscopy, it is actually obvious that both sperm had acrosome circled and mitochondria, particular their structure, was really aberrant. So this gave us kind of overview what's going on with the motility movement issues. So, and I probably forgot to mention that the ultrastructure analysis by the electron microscopy revealed damage of acrosomes and midpiece of the tail with the four mitochondria. So in the next slide, as we were interested why all this is happening, so we wanted to detect what kind of mitochondrial damage is happening within the sperm of testicular germ cell tumor patients. So we focus on individual functional parameters to characterize the scale of damage and discover optimal markers for diagnostics. Therefore, in the last 2 slides, this one and the next, I would like to briefly show you data using kind of highly sophisticated methods, which we use for monitoring of mitochondrial activity in both testicular tissue and sperm in the next slide. So the measurements were done on sections of live respiring tissues, which we kept on ice and transported to our facility and analyzed within 30 minutes from the actual orchiectomy, which was a heroic task, to be honest. The panel on the left is summarizing mitochondrial respiration targeting complexes 1, 2, and 4, and showing elevated oxygen consumption rate by tumor tissue in red. These are rather unique data, I must say, showing that the oxygen consumption rate is higher in the testicular tumor tissue. The panel on the right depicts oxidation reduction status of pyridinucleotides by measuring NAD+ and NADH lifetime ratio, which is produced both by oxidative phosphorylation and also glycolysis. In tumor tissue on the right, the retention of NAD+ is approximately twice as long, about 4 to 5 nanoseconds, as you can see on the scale bar, pointing on slow or slower pathological NAD+ NADH electron and hydrogen exchange. In the next slide, focusing on sperm, we measured both oxidative phosphorylation and glycolysis using seahorse analyzer. And actually we had to develop detection system tailored for human sperm analysis. When comparing normosospermic donor sperm on panel A and B with testicular germ cell tumor sperm on C and D, the most significant difference was in starting level of both oxygen consumption and acidification rate, as you can see on axis Y in all the graphs. And for the NAD+ and NADH lifetime ratio, it correlated with testicular tissue damage, and we detected again elevated retention of NAD+, which is in accordance with other studies correlated with pathological sperm function. So the right panel, it shows the whole sperm under the DIC confocal microscopy, but also with the fluorescence signal overlay, which is depicted on the left. And here you see the elevated levels of NAD+ when comparing with the color scale on the right. So in summary, I hope that I persuaded you that most severely affected sperm parameters, functional and morphological, were detected in the samples of testicular germ cell patients after 6 months from chemotherapy completion. Statistically significant decline in sperm parameters was measured from samples before orchiectomy to after chemotherapy treatment. Cryopreserved sperm samples before orchiectomy represent the first choice samples for assisted reproduction. Assessment of mitochondria function is critical for evaluation of sperm motility and should be included as a novel tool for sperm quality diagnostic of testicular germ cell tumor patients. And at last, acrosome assessment is crucial for prediction of optimal IVF method. It actually correlates with DNA fragmentation, as you may remember from the second slide, and motility, and represents valuable marker of sperm samples quality, despite the methodology which is used for assisted reproduction. And with this, I would like to thank to my colleagues from Laboratory of Reproductive Biology at the Institute of Biotechnology, University Hospitals, Assisted Reproduction Clinic, core facility of BioSef, funding bodies, and you for your attention. Thank you.
So, ladies and gentlemen, after this talk that was really presenting the original findings of Katerina's group, with which we are happy to collaborate, I'm going to review the issue of spermatogenesis and chemotherapy in testicular cancer in general. The topics that I'm going to cover is the effect of various treatments used in testicular germ cell tumor, the timeline of spermatogenesis impairment and recovery, something about post-treatment sperm quality, and a little bit about the offspring of testicular germ cell tumor survivors. So the causes of infertility in TGCT patients are many. There are pre-existing ones. The most prominent is the testicular dysgenesis syndrome, which is known to be a cause of infertility as well as testicular tumors. Then there are disease and treatment related. So obviously, if you have a large tumor or if the patient undergoes orchidectomy, so you will have unilateral loss of testicular function. Then with chemotherapy and radiotherapy, you get or the general loss of germ cells, and you will may get Leydig cell damage and chromosomal damage. Then with retroperitoneal lymph node dissection, there are problems with sexual intercourse and ejaculation, which also can cause infertility, and testicular tumors are associated with some psychological sequelae, which may lead into relationship problems and a decreased fertility as a secondary effect. At the beginning of their course of the disease, about 15% of patients have severe oligoazospermia. This is regardless of histology or disease stage. It is, however, 3 or 4 times more common in patients who have the history of cryptorchism. Orchiectomy may push about 7% of patients who previously had normal or more or less normal sperm counts into azospermia or severe oligozoospermia. The conclusion here is that in some patients at least, we may want to consider sperm banking prior to orchidectomy, although that's normally not how it's done in the clinic. Now I'm getting to the core of my talk, which is chemotherapy, and I've listed here the agents that we use in testicular cancer according to the effect on stem cells. So the most dangerous and the long-term damage can be induced by alkylating agents, which in this case include ifosfamide. Platinum-based agents, cisplatin and carboplatin, may also cause long-term stem cell toxicity, and this is dose-dependent. And it can also induce chromosomal aberration in some patients, but it is slightly less important than alkylating agents. Now we have several agents which actually do kill differentiating spermatogonia, but they do not cause deep sperm cell sperm damage or long-term sperm damage, but they may cause sperm count decrease in combination with other chemotherapies such as ifosfamide or cisplatin. And we know that most people with testicular cancer who receive chemotherapy will receive combination treatment. This is a representative study. There are many studies about the time course of sperm cell damage and about recovery. This is a retrospective, a prospective study with 129 testicular germ cell tumor patients, and it shows that the damage to sperm cells is actually dependent on the number of chemotherapies which are used, which is quite obvious that less chemotherapy causes less damage. Then the most pronounced effect of chemotherapy is observed in people who have a history of cryptorchism, and then also pre-treatment testicular sperm count value is important, because people who will have lower sperm count values pre-treatment will be less likely to recover sperm counts in the fertile range. However, no difference, at least in this study, was observed according to the TGCT type, although this is slightly controversial. There are many studies for and against this finding. We also have adjuvant treatments for testicular cancer, which include chemotherapy or radiotherapy, but the dose intensity is much lower than with curative treatment. So people usually receive just one BEP or one carboplatin for seminoma. Or also for seminoma, more or less historically, they used to receive radiotherapy, but we don't use that anymore. And we see that whereas radiotherapy does cause a deep drop in sperm cell counts at 3 months and then a slow recovery, with chemotherapy which is adjuvant, which is normally one carboplatin or one BEP, the effect is basically negligible. What is important is also sperm quality, not just sperm quantity. There are different ways how to look at sperm quality. One is DNA integrity. This study from 2004 studied 74 patients, and they also had 278 controls. And they actually showed that whereas radiotherapy does increase DNA fragmentation, the fragmentation in sperm cells actually is decreased after chemotherapy. This is somewhat counterintuitive, and the reason, the probable reason is that the cells which have fragmented DNA and receive chemo, so they are more prone to apoptosis. So actually, effectively what we see is a decrease in DNA fragmentation, at least what they saw in this study. However, I have to add that the biological impact of DNA fragmentation at the moment for fertility is not entirely clear. Now, another issue is sperm quality and chromosomal aberrations. And several studies found that pre-treatment sperm in testicular germ cell tumor patients is not completely normal. They have a high risk of especially disomies of sex chromosomes X and Y. And when you give these patients chemotherapy, so the aneuploidy increases, and then the normal values are apparent approximately 24 months after the completion of treatment. So with radiotherapy, the aneuploidy is not as important. Radiotherapy mainly causes fragmentation damage. What is also important for fertility is what we call post-thaw sperm quality. That is the quality of sperm that is actually that is used for in vitro fertilization. That is what is used from the cryobank. And what the studies found that actually the testicular cancer people have lower post-thaw sperm quality, and this is not really depending on the age or stage or various freezing protocols, but it is again depending on cryptorchism. And the recommendation here is obviously to freeze more vials or repeat sperm banking if that's possible within the treatment plan. So the actually the fertility, or the outcome of all the sperm damage is a lower fertility, and it has been shown that the testicular cancer survivors, they have lower fertility than normal population. Also what has been found that interestingly even pre-existing fertility is damaged in people who will later get testicular germ cell tumors, and they also have a lower proportion of boys than normal population. That has been shown in a couple of studies. The reduction in fertility is higher in men with non-seminoma, but this may depend on the intensity of treatment and on the type of treatment which is used in non-seminoma as opposed to seminoma tumors. The fertility is well, what has been studied, or the concern in many of these patients is congenital malformations, and it has been shown that the risk of congenital malformation is really increased in fathers in fathers with testicular cancer. The use of assisted reproduction does not modify the risk, and in fact, this risk is not depending on treatment. So this is again a pre-existing abnormality, and no increased risk of congenital abnormalities was observed in children of men with who receive treatment with radio or chemotherapy when comparing post and pre-treatment conceived children. But as I said before, the risk overall is slightly increased in this population. What is also important is that even surgical treatment, although it does not cause sperm damage, can decrease fertility. In this study by Motol, an interesting study, they show that patients who have non-nerve sparing RPL&D have much lower fertility rates than patients who did not have RPL&D. And this is an important finding, because RPL&D cause damage is a treatable damage, and fertility can be restored by using some special techniques for assisted reproduction. So take-home messages from me. Treatment with chemotherapy does decrease sperm count and increases both sperm aneuploidy, and with radiotherapy it increases DNA fragmentation. Recovery of normal sperm counts and normal sperm parameters depends on type of drugs that are used, on using monotherapy versus combinations, and obviously the number of cycles. There are some studies that if you use more than 4 cycles of major combination chemotherapy, such as 4 BEPs and then let's say 4 TIPS, that impairment may be irreversible. Pre-treatment sperm counts are important, and histology is only important in some studies but not in others. Current recommendations are to wait 6 to 2 years prior to attempting to conceive after completing treatment for testicular cancer with chemotherapy or with radiotherapy, but actually there are no firm data about these numbers. Post or sperm quality may be insufficient, and the effect of treatment on congenital abnormalities has not been detected and is probably not existent in radiotherapy and chemotherapies that we use. Also,
hello everybody, it's a pleasure to present to you a review on the topic of the relationship of erectile dysfunction and testicular cancer treatment. First of all, I would like to remind you the histological classification of testicular cancer, and I will not go through it in details, but the most important group is the group number 2. These tumors are derived from germ cell tumors, and it is the seminoma, embryonal carcinoma, yolk cell tumor, teratoblastic tumors, teratoma, and mixed germ cell tumors. So these are the most frequent testicular cancers. A little bit about the incidence of testicular cancer. Generally, we have 3 to 10 cases per 100,000 males in a year. 1 to 1.5% of male neoplasms are testicular cancers. As I mentioned, most of them are germ cell tumors, and in 1 to 2% are bilateral. On the left-hand side table, you can see the incidence of testicular cancer in some European countries, and on the right-hand side graph, there is an incidence of the testicular tumor among all the malignant cancers in Europe. Here are some data from Czech Republic. You can see that in the last few decades, the incidence of testicular tumors are increasing, still going up. And even though the morbidity is decreasing, it is not still approaching a zero level. And what is the most important thing is the right-hand side picture. It shows the incidence according to the age of a man, and demonstrates that the testicular cancer occurs mostly in men, and when they in the professionalized, they are on the top of performance. Here is the definition of erectile dysfunction. Erectile dysfunction is the persistent inability to attain or maintain an erection sufficient to permit satisfactory sexual performance. It is one of the most common complications of testicular cancer, with the prevalence of 13 to 84%. It has a devastating effect on quality of life, and the etiology can be either organic and psychogenic, or the combination of both. Here is the etiology of erectile dysfunction from the just organic etiology. In a case of orchiectomy, it is usual the low testosterone levels, so-called hypogonadism. In chemotherapy, in radiation therapy, it is mostly the toxicity to the pelvic blood supply, damage to the nerves, and also the hypogonadism. And in the case of retroperitoneal lymph node dissection, it is the damage to the nerves in the retroperitoneum. So, what is the cause of erectile dysfunction after chemotherapy and irradiation? Here you can see the list of the causes on the cellular or subcellular level, but generally we can say that both therapeutical modalities are highly associated with induction and acceleration of atherosclerosis. This is the main cause of the erectile dysfunction. What is the relationship of erectile dysfunction and hypogonadism? Hypogonadism is defined as the total testosterone levels below 12 nanomoles per liter. And if the levels are below 8, there is a very strong association with erectile dysfunction. The incidence, the risk of hypogonadism after the testicular cancer treatment is shown in the table. And you can see it is 11% after orchiectomy alone, 13% after adjuvant chemotherapy, 15% after irradiation, and even 34% after the combination of all modalities. Yeah, what is the relationship of erectile dysfunction and hypogonadism in the long term? You can see on this graph. And while with the upcoming years, there is a decline of hypogonadism after orchiectomy. There is a significant increase in hypogonadism after chemotherapy, and a slight rise of hypogonadism after radiation. So what Here you can see the list of causes of hypogonadism after the irradiation and chemotherapy treatment. So relation between the erectile dysfunction and chemo and radiotherapy can be just the primary effect of radiotherapy and chemotherapy on the erectile dysfunction, also as a secondary effect through the hypogonadism. We can divide the chemotherapeutic agents into the risk groups according to the relationship with the erectile dysfunction. So you can see the most used agents in testicular cancer, just platinum agents and bleomycin at opposite. They belong to the medium risk or low risk group according to the relationship of erectile dysfunction. There is also a psychogenic etiology of erectile dysfunction, of course, usually through the changes in the body image. There is a loss of sense of manliness after orchiectomy, of course, reduced feeling of well-being, and other psychological fluctuation like depression, anxiety, and so on. And over 50% of patient reports minor body image changes after orchiectomy, and about 15% reports just moderate body image, and it has usually very severe and sometimes devastating influence on the quality of life of men after orchiectomy. So when it comes to the erectile dysfunction and the workup for it, of course, at first we take the patient's history and we focus on the onset and duration of erectile problems and so on. What helps us a lot is a questionnaire that we use, International Index of Erectile Function 5. This is a internationally validated questionnaire of erectile dysfunction with the scales shown in the bottom of the slide. So we can distinguish between the erectile dysfunction, some degrees, and is it. After that, we perform physical examination. We take a blood pressure, count a body mass index, and perform a physical examination of the whole body, not only of the external genitalia, but also we make the examination concerning just gynecomastia, body hair loss, and very important is also digital rectal examination, as you will see later on. We also perform some blood samples to evaluate the hormone levels, especially total and free testosterone, also prolactin, luteinizing hormone, follicle-stimulating hormone. The blood samples should be taken in the morning because of the circadian circle of the hormone levels. And in a hypogonadism, we typically see elevated luteinizing hormone and follicle-stimulating hormone and low total testosterone. Of course, we examine also the PSA to exclude prostate cancer and renal and hepatic functions and glucose lipid profile. When it comes to the therapy, if the cause of the erectile dysfunction is a hypogonadism, we start with the testosterone replacement therapy. We start with the total testosterone levels below 12, and there are several studies declaring this replacement therapy improves quality of life and total morbidity of the patients with the hypogonadism after testicular cancer treatment. The most used agents are either parenteral, this is testosterone antagonist. It is administered in a 3 months period, and testosterone ester mixture, which is administered intramuscularly, also is intramuscularly in a 3 weeks time intervals. We also can use the transdermal agents. It is a native testosterone which is administered daily by a pump. In terms of the replacement therapy, we should also consider the contraindications. Here you can see the absolute contraindications, which is the prostate cancer, breast cancer, men with an active desire to have children and a high hematocrit, and a poorly controlled congestive heart failure. When it comes to the treatment of erectile dysfunction, we proceed according to the recommendations of European Association of Urology, which we start from the minimally invasive to the most invasive treatment. So we usually start with the oral therapy. We have several agents we can use: sildenafil, vardenafil, avenafil, tadalafil, and we can actually tailor the treatment for each individual patient according to his needs, because each agent has a different time of effect duration and the start of effect. We have also agents for the intraurethral administration. These suppositories are applied in the meatus of the urethra and sometimes have adverse effects as a swelling of the meatus and the urethral mucosa. More invasive treatment in the case of failure of oral treatment. Oral treatment failure is the intracavernosal injections. We use alprostadil, which is a prostaglandin E1 usually, and there is a titration of the dosage, which comes from the 2.5 micrograms to 60 micrograms. It should be very carefully titrated. In case of failure of intracavernosal injections, vacuum device can be used for the penile erection achievement alone or with combination with the oral therapy. And the most invasive treatment is the implantation of penile prosthesis. There are different kinds. There's malleable or inflatable penile implant, and this is the treatment of the last resort. Thank you for your attention.
Thank you. Okay, that's all the presentations completed. So thank you to everybody. So people will now want to send questions in. please do so. So we'll give you a few moments to do that. Just whilst we're waiting, just a reminder that this webinar will be recorded. We'll send the links out, direct links out tomorrow to the edited recording. Attendees will receive a survey directly after this, after the session finishes. So anybody, we welcome feedback via that if you have time to do so. Hopefully you should also receive an attendance certificate as well, those who are attending today. Apologies if you don't get that, we have had a few issues. Please let me know if you don't, because we are raising those issues with GoToWebinar to try and sort that out. But hopefully the link you will be sent the link. Okay, I think that's everything for now for that. This is the last, just to quickly say, it's our last webinar before our summer break, so we will restart in September. Okay, so we have got one question come through, so I'm just going to take, if everybody else wants to put their cameras back on, I will stop screen sharing as well. Second. See Thomas, Katerina, you.
I'm trying to enable the camera. The whole panel disappeared how to enable the camera, so but microphone should be on.
Yeah, I can hear you. That's fine. If it's problematic, that's not. Don't worry. Okay, we've got a question from Joseph Maransak. It says, what ultrasonographic scrotal findings do you consider suspicious of a testicular tumour? In this regard, how do you evaluate the presence of testicular microcalcifications? Is that all?
So this is the question for me, right?
I don't. Yeah, whoever else you think is best to answer. I don't. They're a particular presenter. So.
Yeah. Actually, I didn't hear the end of the question. We use the ultrasound for the diagnosis of the testicular calcification, or?
What is the importance of microcalcifications? Whether you think that this is a tumor, more or less.
There have been performed several studies that evaluated the risk of the testicular tumor in case of ultrasound finding of microcalcification, and no strong connection between these two aspects have been found. So the patient, we usually follow the patient with the microcalcification, but we don't perform a biopsy. So.
Okay.
Yeah, if the answer is, the response is sufficient.
Yeah, I think hopefully Joseph also said thank you for the great presentations as well to everybody. So hopefully you'll let us know if he's okay with that, if he wants to ask any follow-up. So another question. Again, this is from Video Beaker. He says thank you for the great presentations. Do you have a fertility preservation program in your country for children, for or young patients, also for pre-pubertal ones?
Well, it is not an organized program, but this is reimbursed. So there is a reimbursed option for basically anybody to cryopreserve their sperm, not just well, obviously postpubertal kids and adults. If you have a very small children prior to puberty, not able to cryopreserve sperm, there is no organized program though.
Okay, thank you. So, okay, no other questions at the moment. So if anybody else wants to ask a question, please do so now. Let's give you a few more seconds to do so. I'm sure other things I meant to say as well, which I can't remember what they are. I should rewrite these down. Okay, so we've got no other questions. So I think that's probably it. We are actually on 7 o'clock as well, so that's kind of perfect timing. So So just quickly, for any attendees, if you do think of questions afterwards, you'll have my email address for you via the registration contact and everything. So please send them to me, and I can always pass them on. Otherwise, you can also, if anybody wants to, you can comment on the YouTube videos, for example, as well. Our business manager Jen will keeps track of those as well. Any comments that are made there. So those are alternatives if you think of things later on, and anybody watching this video back can do that as well. Thank you for everybody for attending, and most of all, thank you to our presenters this evening. Thank you all for taking the time to do this. I know it's not always easy, and we have to do all the tests and everything beforehand, so thank you for taking the time to do all of that. And yes, thank you very much, and I hope everyone has a good evening. Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you very much. Thank you. Bye-bye.
Bye.
Bye, everybody.